Hello, Public Health 105. This is the history of healthcare, and this is the fifth lecture, which is on basically 1990 to 2022 to move to universal care. So just to remind you, when we're talking about the 1970s to 1990s, we said that, well, there are three types of problems that started to develop in the 1970s. First, medicine stopped making big advances, and so that the smaller advances came with larger costs. The second is that there was increasing complexity to healthcare. And what that did is it did two things, really, or three things. One is that it caused more medical misadventures. Two is it's kind of elevated the status of healthcare professionals to being sort of the exalted states that we now think about them. And then third is that it suddenly brought to the fore this need to coordinate or integrate care. The third thing that happened then is that for the first time in history is that healthcare providers could do more for people than they could afford. And so cost becomes a major focus during the starting in the 1970s. And cost is still the major focus in healthcare, at least in the United States. So by 1990, we said that the HMOs were vilified as being heartless and that costs kept rising. Quality was a bigger issue, and more people were without health insurance. So HMOs were vilified because at first they tried to basically limit the type of, needed like approval to get certain types of care. And so they were bashed in the press. And then they started through a pathway of what's called rescissions, where they went through and they started to deny coverage for people once they made a claim. So they were vilified. Costs kept rising because there was really no way, HMOs were supposed to control costs, but really they ended up not controlling costs that much. Quality was becoming a big issue, as we discussed, with the medical misadventures. And then more people were without health insurance because you had a lot of, one is loss of manufacturing jobs. And so with the manufacturing jobs and move over to service jobs, people didn't get health insurance. And then a lot of people who had health insurance had what's called, these high deductible, high copayment type plans, so that it really didn't cover very much. So by the 1990s, probably a third of the people didn't have health insurance or either had this, this poor type of health insurance. So 1990s came and, America needed a bold plan. Enter Bill Clinton. So the Clinton, was elected president in 1992. And one of the things that he ran on was basically to do a healthcare plan. So what Clinton did is that he appointed his wife, Hillary, who was the first lady, to basically lead the development of this healthcare plan. And Hillary Clinton then got together a small group of kind of advisors, and they kind of came up with a plan. And so the plan that they came up with was that each citizen was going to be enrolled in a qualified health plan, that you couldn't disenroll until you're covered by another plan. So if you wanted, you couldn't just sort of not have a health plan, you had to have one. There were minimum coverages and maximum annual out-of-pocket expenses for each plan, so it would be subsidized by the government. There were regional alliances that could be subject to a fee-for-service schedule, meaning is that if you had, if you didn't have like a Kaiser that you're going to get your healthcare through, is that then you would have to go through and there would be limits on what they would pay for fee-for-service. And that people below a certain income level were to pay nothing. So essentially, you pay nothing up to a certain point, and then you sort of the amount that it costs you started to go up after that. So they introduced this plan, and that it was instantly panned. It was dead from the outset, never went anywhere. Got to Congress, and Congress just said, this is dead on arrival. Part of the reason for it was that there was a massive insurance company resistance. And there was something that's called the Harold and Louise ads. So if you go on YouTube, I'll give you the little link here, and just watch some of these ads, you'll see what they did, which is they were all sponsored by the insurance companies, but they also had the support of the American Medical Association, and that they just vilified this idea of this government-run healthcare plan. So if you look back on this and say, well, why did it fail? Well, one of the lessons was that it was done in secret. And so it didn't really involve Congress. And so when it finally got to Congress, there are all these insurance companies who are already bashing it. And so Congress was like, well, no one was going to stick up for it. And they didn't have the doctors on board. So you had insurance companies and doctors both saying that this was a bad deal. So it just never went anywhere in Congress. So meanwhile, things are sort of developing elsewhere. And so the state of Oregon, bless their little socks, went through and did an experiment where they had the problem with they had all these people who were eligible for Medicaid, and they couldn't pay for everything for everyone who was eligible. And so they thought, well, what we'll do is we'll try to, rather than limit the number of people who get Medicaid, we'll limit what we pay for. That's how we'll limit the amount of things we're going to cover. And so they figured what they would do is they would do this kind of experiment where they would see it if they could come up with a list of what they would cover and what they wouldn't cover. So what they were trying to do is they were trying to identify essential care. Now this is really controversial when Oregon does this, because there's sometimes you'll hear prioritization of healthcare, like coming up with these types of lists called prioritization, which means that, oh, we're just going to identify what our highest priorities are. But sometimes it's called rationing. And rationing has this bad term, that's bad connotation, which means that we're somehow, going to cut out essential care. And so the problem that they faced was basically how to go through and come up with this list of essential care that was seen as prioritization, but at the same time wouldn't be seen as rationing, whereby they're trying to limit necessary care. So that was the idea. And so what they did is that this was motivated by the death of a 7-year-old boy named Kobe Howard, who was on Medicare and needed a bone transplant, but it wasn't covered under the Medicaid plans, and so the boy died. And this sort of began to fuel a big debate. Now, in retrospect, Kobe Howard didn't get the bone marrow transplant for other reasons, not just because he was on Medicaid, but a lot of the focus from this came upon the fact that he was on Medicaid and it wasn't covered. And so that's what kind of led to Oregon to try to do something to come up with this plan for what they were going to cover and make sure that what was on their Medicaid schedule that they would pay for were things that people wanted. So they started this prioritization experiment where what they did is that they tried to get, first off, they started with certain principles. And so they said that access to a basic level of care must be universal. So everyone must get the basic things, the essential things. Society is responsible for financing the care of the poor. So therefore, that says that they're going to, it's not just something that they can cut out, and that a basic level of care must be defined through a public process. Meaning is that they were going to go out there and try to use polling and things like that to try to figure out what this basic level of care is, what these essential services would be. So they put together a health services commission that had 11 members, 5 doctors, 1 DO, 4 consumer members, a public health nurse, and a social worker. They then went through and they had a very complex cost-benefit formula. When what they used what's called quality adjusted life years, QALYs, and that the QALYs then was going to be the measure that they're going to use. So what they plan to do is that they would get all the different types of things that potentially could be purchased by Medicaid, and that they would then go through and figure out what the quality adjusted life years were. That is, that how much quality of life did it add to someone's what was the quality of life and the life expectancy that added to someone's life, and then they would use that to base it to sort of say, okay, so is it worth it? And what they would do is they would sort of they would weigh the quality adjusted life years and the costs to come up with a list of something that was cost effective. It was called the cost utility analysis. And so that's kind of what their goal was. So they did lots of interviews and surveys, and they went through and they did these so they did lots of interviews and surveys, and they also then brought it to these to this group to kind of decide, well, what's this list going to look like? So their initial list, it had a lot of things that we would sort of think were sensible. So you had highest categories was 1, and the lowest category was 6. So category 1 was things like birth of a child, right? that was seen as really important. Preventive care was important. Life-threatening diseases were important, et cetera. But then, and in category 6, you had non-fatal, you had elective, inconsequential conditions or interventions, things that you would kind of expect. But there were some peculiar types of things that came out. So, for example, it covered tooth caps, but it wouldn't cover surgery for emergent appendectomy. So what happened is that, well, they, this panel, this health, they kind of said, all right, we're going to take this list, but we're going to tweak it somewhat. So one thing that always happens when they try to do these types of service, these types of prioritization things with services, is that public health tends to come out really bad, because people say, well, how much do you want a diabetes prevention program that's going to show results in 20 years versus a surgery that's going to show results right now, and the public health programs always look worse in that case. So this committee didn't want to kind of gut all public health type things, and so they did kind of adjust the list. So they kind of used what the public said, but also kind of used what what they, in their medical knowledge, that they thought would be beneficial. Well, so the results is that it was implemented and still used in Oregon, still the basis for their Medicaid purchasing. It didn't really have as dramatic as impacts they thought. I think they thought that this was really going to control costs, but it really didn't. And part of the reason is because, a lot of the things that are seen as urgent are really costly. And a lot of the non-urgent things that were low priority just don't cost that much. And so they really didn't come up with a lot of high cost, non-urgent things that were low priority that they could cut out. So as a result, it kind of was a good concept that everyone, still to this day, it's seen as important, which is why we're talking about it. But it also shows how tough it is when you try to do one of these prioritization processes, because you're going to be cutting out things that people say they need, and the things that people say they need tend to be very expensive, and that's a basic problem. Okay, but even though the Clinton healthcare plan failed, there were other things that happened. So, for example, in 1997, that's where they introduced Medicare Part C. So just to remind you, when they introduced Medicare initially back in the 60s, there was a Part A, which was covered hospitalizations, and a Part B that was optional, that covered your doctor's fees if you wanted to. And so in 1997, they introduced Part C, which is the Medicare Advantage. And what that basically did is that it got people into HMOs. And so you could use your Medicare benefits to purchase a private health plan. So for example, my mother, 97 years old, she has Kaiser. She's had Kaiser for probably 50 years. So when she went from working to retired, is that she was able to keep and retired and going on Medicare. She was able to keep her Kaiser, because what she did is she switched over to a Medicare Advantage plan. So that meant that Kaiser got some money, her Medicare money, from the government. They still got some money from her on a monthly basis, and they got some from her former employer. So they have these 3 different types of income sources that they use. But from my mother's standpoint, she's a Kaiser patient. She's treated just like any other Kaiser patient, and the fact that she's a Medicare Advantage doesn't really enter into it at all. So that's why they introduced this, because they thought, well, okay, if these HMOs are better at controlling costs, maybe better at coordinating care, then let's go ahead and introduce them and make them available to people. So that's what they did with the Medicare Part C. So as of 2007, 10 years later, about, 1 in 5 were on a Medicare Advantage plan. So they did take off. The difference was regional, is that you saw some places like out here in the West, you saw higher levels of Medicare Advantage plans, and down in the South, you saw lower levels. So, there's various reasons for that. But what it means is that, out here in California, about a third of people who are on Medicare are in some type of Medicare Advantage plans. And as we'll talk about after the midterm, is that what Medicaid is doing now is Medicaid is moving towards getting everyone on Medicaid or Medi-Cal into essentially an Advantage plan. All right, so then, time marches on and 2000s come along. And this is where Medicare Part D then gets introduced. So Medicare Part D gets sort of ratified in 2006, I think it is. And what Part D did is it paid for prescription drugs. So prior to Part D coming through, Medicare didn't cover prescription drugs. And so, back when in the 1960s, not that big of a deal because, people could get drugs if they were on treatments for something. But if you were just like, if you had diabetes medication or something, then it wasn't covered. But not that many people had chronic diseases and the medicines weren't that expensive. By the 2000s, they were really expensive and a lot of people were taking a lot of drugs. And so they introduced Part D then to cover drugs. So the way it works is that when you first go on Medicare, is that they ask you, do you want to be on Part D? And if you want to be on Part D, then you pay $40 a month and then you have this deductible. If you say, no, I don't want to go on Part D, and then you change your mind later on, then they charge you a whole bunch more. So what they're trying to do is they're trying to avoid adverse selection by giving an incentive for people to basically come and to join Part D right from the start so that you have enough kind of low-cost people, low-cost meaning those who aren't necessarily using a huge amount of drugs, purchasing that at this $40 a month, which will hopefully then offset some of the costs that go into that for the people who are higher cost. And what the coverage said is that it said, well, is that you're going to get 75% of the drug costs until 2,840. And then there's a gap. So essentially, once you reach 2,840, then you get kind of a discount on some drugs, but for the most part, you're paying for most of it until you reach 4,550. And once you're past 4,550, then you have a small copayment of or 5% on all medications. So this kind of coverage gap was referred to as a donut hole because it meant, if you were up to $2,800, you were having most of it paid for. And then once you got past $4,800, you had most of it paid for. But in the middle there, you were paying for most of it. So that was a big deal at the for when Medicare's when Part D kind of rolled out, because these people realized that yes, they were gonna, for people who were low cost, small users of drugs, then it was it was going to be mostly paid for. For people who are high users of drugs, it was going to be mostly paid for. But for people in the middle, is that then it wasn't really benefiting them that much. All right, so the health impacts. Medicare beneficiaries who reported foregoing medications due to cost dropped from 15% and to 11%. So what does that mean? Well, that's usually a sign of if people forego medications, that's usually a sign of kind of that they don't have access to the healthcare they need. So the fact that it dropped from 15 to 11, that says, okay, that's what this was about. This was about getting people more medications. There was no evidence for improvement in emergency use for hospitalizations or quality of life, and that there was a decrease in the use of generic drugs. So, that second point means that it didn't necessarily lead to all these cost savings. So there was this sense that, oh, well, maybe if we provide medications for people, we'll keep them out of the hospital, and didn't really see that. And we thought that maybe if we provide more medications for people, we'll see improved quality of life. Didn't really see that. What you did see is a drop in generic drugs, and generic drugs are priced a lot lower than brand drugs. And that makes sense because now, before, when people were paying for most of it, they might want a generic drug, but now when most of it's being paid by, by Medicare Part D, then, that's moral hazard. And that's an important point, that's what moral hazard is, right? This idea that this increase in the use of decrease in the use of generic drugs, that's what moral hazard is. Because once people got insurance, then they stopped trying to save money. And they stopped trying to save money by using, in the sense of using generic drugs, and went over to using brand name drugs. That's moral hazard. Okay, so who were the big winners from Part D? Well, people with catastrophic health conditions, definitely big winners. But the main big winners was pharmaceutical companies. It turns out that when the government comes through and starts to pay for drugs, people use more drugs. And so that's what happened. You had increased access to prescription medications, and that there was also then, more people were using brand name drugs. The other thing that happened is that at the time is that the government is that Medicare Part D restricted Medicare from negotiating over prices. So, this was a big deal because if Medicare is going to start paying for drugs, then they could have said to Medicare, okay, you can now negotiate prices. So, for example, if there's two companies that made the same, made a heart medication that someone needed, what they could do is they could go to one and say, well, how much will you sell it for? And that then they would go to the other and say, well, can you sell it for less? And they might say to the second company, look, you sell it for 50% of the price of what we pay now, and we promise that all of our warfarin, our stroke medication, will buy it from you. So they could have gone through and used that type of negotiations to basically lower drug prices, drug costs. That's actually what other countries do. So if you look around the world, when they talk about why it is that the US pays more for drug costs, which we'll talk about in a while, is that it's going to come down to the fact that, well, partly the US doesn't negotiate drug prices. We pay full prices for drugs. And other places, like overseas, they have a place called Pharmac. Excuse me. And Pharmac negotiates drug prices. But they didn't. They restricted it, and so therefore we have no, there was no negotiation. I point this out just because when we get to 2022, one of the things that just occurred when Biden just signed in the latest Build Back Better bill was that it allowed Medicare to negotiate drug prices. So that's a big deal. That's been talked about for a long time. Okay. The other thing that was going on at this time was in the 2000s was the Massachusetts healthcare insurance reform. So beginning in 2004, political leaders began to talk about maybe having a universal healthcare system in Massachusetts. So the Senate president went and called for a plan to reduce the number of uninsured by half. And Mitt Romney, whose name you might recognize, was governor at the time of Massachusetts, and he announced a plan that would cover virtually everyone versus all of the uninsured. And so it was passed in 2006. So what it did is it had four main features. So first off, it had an individual mandate. That said that everyone has to buy health insurance or they pay a fine. And the penalty was about $900. Then they had employer mandates. Essentially, all employers with more than 10 workers had to provide health insurance for their workers. And if at least they must make a fair and reasonable contribution to it. So in essence, what it did is it said, look, you either provide health care to your workers or you pay a sort of a tax that's going to go to helping them subsidize their health care. Large government subsidies for low income. So less than the federal poverty line, the government would pay up to 300%. The government would provide subsidies of the federal poverty line. And then what it did is it created a single healthcare market in the state, this state exchange, where basically it had universal rules that all the policies had to have a certain type of they had to have certain restrictions on premiums. They had to cover certain things, like they all had to cover, contraceptive care, and they all had to cover, preventive care, and all the other things that kind of, that go into a good healthcare plan. They had to cover, and anyone who wanted to sell insurance had to be approved, had to be an approved plan. So they all had to put in for this approval. So what happened? Well, it was popular. The public was favorable and physicians were favorable. Public was favorable because, it gave people health insurance. Physicians were favorable because it didn't really, screw around with their incomes very much. And it, got more, frankly, it got, more people, the government to pay for more people. That's one of the things about providing healthcare, government providing healthcare to the uninsured, is that the people usually make out are like hospitals, because hospitals have to treat people because of EMTALA, who, regardless of whether they have insurance, but they may not get paid. And what this did is it got people paid. So what it meant for in Massachusetts is that suddenly there was a big push to get people on one of these plans. So if somebody would come in who's uninsured, healthcare providers would say, "Oh, let's sign you up for on one of these plans here." What happened to the level of uninsured? Well, it was 6% of people in 2006, and then it dropped to 3.5%. So that's what this plan was trying to do: is get more people healthcare and reduce the number of uninsured, and so it worked. It also reduced unmet need. So therefore, like unmet need fell by 2%. Now, unmet need is kind of an indicator about when you have unmet need, it means people say they need healthcare, but they don't get it because they don't have health insurance. So, this showed that, yes, it did decrease unmet need, which is a good thing. It had more limited success for vulnerable communities, like, little improvement for Blacks and Hispanics and people in poor health. That's not, that we're going to see that again when we start talking about the Affordable Care Act, because that is one thing that, the thing to remember is that there's a lot of reasons why people don't get health insurance. One of them is cost and availability, but there are lots of other things as well. And so that's why you need to have programs that are tailored to people if you want to get, if you truly want to get expand, or reduce the healthcare coverage, reduce the number of unemployed. Impact on health expenditures, well, little impact, right? That was, that's either a glass half full or a glass half empty. Little, you could look at that and say, well, gee, look, you get all these people health insurance and it didn't really raise health expenditures. And so that's, good. You could also flip it around and say, well, we got all these people access to primary care and preventive medicine and everything else, and it didn't really lower health expenditures, which is also true. And that's partly because, most of the big ticket things that the big items that cost money are things that people need and that they're going to need regardless. And so, really, if you look at what does health insurance kind of do on the margins, it tends to, kind of do some primary care, but mostly it does preventive stuff. Is that if you don't have health insurance, you're much less likely to get cancer screenings and get other type of preventive type measures. It's found that the health safety net funding dropped by 40%. And that's going to be important because once the Affordable Care Act comes in, that's when they come through and they cut the public health departments, the local public health departments, by about 50%. And it was because they looked at this and they said, oh, well, look at, when you provide everyone with health care, you don't necessarily need to have, the public system doesn't need to provide any type of services that the public health departments don't need to. Private healthcare spending per member in the state increased at an annual rate of 7%. That was mostly due to price increases, and price increases tend to be things that rather than volumes, so that price increases sort of affect all health insurance. So that there was, some increase in costs in the price per person, but it was not necessarily due to it was mostly just due to the fact that healthcare costs were rising everywhere during that period. Okay, where did this idea come from? Well, this idea actually came from the Heritage Foundation. That is, the Heritage Foundation is a conservative think tank. So if you notice about this, you compare the Massachusetts plan to the Clinton plan. The Clinton plan basically said everyone is going to get health insurance, and all the, and that we're going to offer a policy, and that, approved policies, and that private companies can offer approved policies, but for the most part, we're controlling everything like that. Well, what this plan was a much more market-based. That is, that there was no kind of government healthcare plan. What it did is that basically just sort of said, well, we're going to let, people, so just going to require that that people buy insurance. So we're just going to expand the private insurance market. Yeah, we're going to come through and say, insurance companies, you have to offer certain types of policies. But for the most part, it wouldn't, you're not going to go through and have a government running the healthcare system. All you're doing is the government is just paying for the healthcare system. And the idea was, and the reason that this came out of a conservative think tank, is that they thought, okay, private choice, the competition between plans would help keep costs down, because what would happen then is that, people would search for the lowest cost plan, that since they all offered pretty much the same thing, they would search for the lowest cost plan. So this would give an incentive to insurance companies to basically try to control costs. Because if you could control costs more, that is, that if you could pay the doctors less and the hospitals less, or if you could keep people healthier, is that then you could charge less on premiums. And so the idea is that it used market forces to basically reinforce things. At the same time, there was another Oregon experiment. We'll call this Oregon 2. So Oregon 1 was the prioritization experiment. Oregon 2 is basically to see whether Medicaid works. And this was a, bless Oregon for doing this. Oregon, continued to have the problem is that their costs were higher than they couldn't afford that. Well, they didn't want to spend the money to cover everything for everyone who was eligible for Medicaid. So before, back in the 1990s, they had tried to say, well, let's limit what we cover. That didn't really control costs. So now they said, well, okay, so what we're going to do is we're going to just do a lottery. We're just going to take all the people who are eligible for Medicaid, and we're just going to do a lottery and just assign, a certain percentage of them you get Medicaid, the rest of you don't get Medicaid. And so that's what they did. And so it was random. So it meant that, you could actually go in there and see what's the impact of getting Medicaid. And what they wanted to see was basically, well, are there going to be huge negative impacts? So what happened? Well, for those with insurance, hospital utilization increased by 30%, and the length of stay increased by 20%. And the number of procedures increased by 45%. So that makes sense. You give people insurance and they're going to use more hospitalizations. Medicaid provided more likely to seek, the people on Medicaid got preventive care. That makes sense as well. People who had insurance had 10% lower chance of having an unpaid bill sent to a collection agency. That makes sense because, one of the big problems with, like, if you don't have insurance and you go into the hospital and they charge you, is that you don't pay, then they send it over to a collection agency and then they try and collect from you. In terms of health outcomes, there wasn't really that much sort of big health outcomes. As that self-reported health went up, right? And that mental health went up. But you didn't necessarily see kind of an increase in life expectancy. So helped with depression, helped with self-rated health, got more hospitalizations, got more preventive care. But at the same time, it was more costly. So was it money well spent? Well, if you look at, they're still spending $400 billion by 2010. There didn't appear to be much relationship between cost and quality of care, in the sense that, that those who are on Medicaid didn't sort of get better quality care than those who are not on Medicaid. And that there was the potential to reduce costs without harming quality, or improving quality without increasing costs, didn't really seem to work out. So the implications were that, well, there's sort of two ways to look at this. Is that those who didn't like Medicaid say, look at, you spend all this money on people, and all that happened is that they get a bit more preventive care, but there's no change in life expectancy, and they just use hospitalizations more. On the other hand, the people who were for Medicaid turned around and said, well, look at you wouldn't expect to see changes in life expectancy because people still are getting the essential care. But what you're seeing is that people getting, kind of a more preventive care and things like that will lead to better health in the future. So it didn't end the Medicaid debate, but what it did do is it sort of really helped to define what exactly happens with Medicaid. What happens when you give someone Medicaid. Okay. 2008 election. This is, the Democrats have Hillary Clinton versus Barack Obama, and that healthcare coverage was a major issue in the 2008 election. And both of them had plans. So both were based on the private insurance market. Both sought to expand Medicaid coverage, both eliminating pre-existing conditions, and both focused on prevention. The difference is that the Clinton plan required everyone to buy insurance, but an Obama plan didn't initially. So when Obama first kind of proposed this, he didn't require everyone to buy insurance. Clinton plan, limited premiums at a certain percentage of income, But Obama plan was basically going to just reimburse employers for high costs. So the initial Obama plan was going to be is that, well, if we're not going to give money to subsidize people per se, but what we will do is that if you have someone who's a high cost person, is that then we're going to put you in a special pool and we'll reimburse from that. That was an idea actually that was being tried in Minnesota at the time, which is kind of where Obama got it. Is Minnesota had set up this high cost pool whereby if you were insurance company and you had someone who's really costly, then you could put them in this pool, and then the state would pay for their really, really costly care. So it was just sort of another way of keeping premiums down, because if you think about like the examples we've done with high costs, with insurance premiums, it was essentially just taking all those group 4 high cost people and saying, well, you don't have to pay for these. When you do, premiums go down when that happens. So that was Obama's plan, but really they were pretty similar. Okay, Obama gets elected, has a big crowd at his inauguration. And one of the first things that Obama does is that he proposes a healthcare plan. Now, remember, well, maybe you don't, but at this time, in 2008, when he gets elected, was right when the financial markets are crashing. And that, I mean by crashing, like, they were looking at Great Depression, like the massive bank failures everywhere. So it was really, really a time when we were as close as possible, as close as you could come to essentially having the economy just free fall into a depression, like in the 1930s. And so when Obama takes office in 2009, when he actually starts office, what the first thing he does is deal with the economy. So they pass these relief bills that basically come through and try to bail out banks, and they try to bail out some of the financial institutions and things. But then he also starts with healthcare, and he was advised at the time. He said that this advisor said, "Look at you've got the economy stuff going on right now. If you do healthcare right now, is that it's going to be too much. Just wait until your second term to do healthcare." And Obama, to his credit, realized that if you look at presidents typically they can get most of the things done in the first 2 years. After 2 years, is that presidents typically don't get much done, and that's Republican or Democrat. So Obama realized that he had a short window to kind of get this done, and so he pushed through kind of to start this process of having a healthcare bill. All right, so how does a bill become a law? I'm going to go through just to make sure that you understand. So the way that a bill becomes a law is that you have the House of Representatives and you have the Senate, and they each have to pass a bill, and the bill then has to be passed by a majority in each house. So 51 senators or the 216 or 218 House members. That's what you need to get a bill passed. Then what happens is that the bill then comes to the House and the Senate gets together, and they reconcile any differences between their bills. Then the bill goes back to the House and Senate, the revised bill that's the same, and they go through and they vote again. And then if they both approve that, then it goes to the president, and then the president signs it. If the president at that point can say, I don't want to sign it, that's called doing a veto. But once it gets to that point, the president can sign it. There's a little twist to this, though, in that in the Senate, even though you only need 51 votes to kind of to pass something, the Senate has just adopted this rule that you have to have 60 of the senators agree that they're going to let a vote go forward. So you only need 51 senators to pass a bill, but you have to have 60 senators who say, oh yes, we're going to let this thing go forward. The exception to that is that you can pass bills that are finance bills, that are just money bills. You don't have to do that 60 thing. So that's and what that is, then that's so you'll hear them saying, oh, we're going to pass this bill through reconciliation in the Senate. What that means is that it's just a budget bill, so they don't have to have the 60, and that they at that point then they just need 51. So like the tax cuts that were implemented during the Trump administration, all they needed was 51 votes. They didn't need any. They didn't have to get 60, because all it was doing is just changing money, and money then changes. You only need 51. However, if you want to do things like change, let's say the way that what you're going to require of insurance companies, then that's a real bill, and that requires 60 senators. So that's kind of the way that normally things happen. Well, things got a little wonky, and when Obama first took office, there were 60. He swept into office. There were plenty of Democrats in the House, and he had 60 Democratic senators, or 60 senators who were going to vote with the Democrats. So it meant that they actually could pass a bill because they had these 60 senators without having any type of Republicans. Now, Obama, though, really, really wanted this to be a bipartisan bill because he knew that if you only have one party pass things, is that then the other party can always just try to undermine it. And so he really wanted to be bipartisan. So what he did is that he did, unlike Hillary back in the 1990s, he basically said to Congress, okay, Congress, you write the bill. And his hope was that then, that he would get enough moderate Republicans to kind of come on board so that it would be not just the Democrats, but also some Republicans as well. So it'd be a bipartisan bill, and then it would not be challenged, or not as likely to be challenged. So that was the base, that was the goal. And so, what happened then is that it just got drawn out for a long, long time. For like a year, it gets drawn out because all these senators were saying, oh, we're still negotiating with our Republican colleagues. And in the end, no Republicans voted for it, even though, if you look at the bill that came out, is basically the same thing as the Massachusetts bill. That is that it's the Heritage Foundation conservative think tank. And the reason that Obama went with that is because he thought that he could get some Republicans to kind of come along, and also conservative Democrats. They could get conservative Democrats and Republicans to kind of come through and agree to it. But in the end, no Republicans kind of voted for it. Well, so, okay, it goes through and it passes the first stage, right? And now they have to do this reconciliation. But during this reconciliation, Edward Kennedy dies, who's the senator from Massachusetts. And so they have a special vote in Massachusetts, and a Republican gets elected. And so suddenly Obama loses his 60 vote cushion for this thing. And so it meant that they had to pass a lot of the Affordable Care Act under this budget reconciliation thing. And what that meant is that if the Republicans wanted to undo it, all they need is 51 votes. So the first time that they took control of Congress and the presidency, they could just vote out the entire, all the key provisions of the Affordable Care Act. And so it was this odd kind of, twist of fate that Edward Kennedy, who made his life's work in the Senate is to try and get healthcare passed, was the one who, when he died, he actually caused the Affordable Care Act to be to be passed in such a way that the Republicans could undo it. But they got it through. They got through budget reconciliation, and they with a simple majority. And so then Obama signs it into law. So, then I won't go through all the details about what happens through this, but essentially, that it starts to be implemented. Like, one of the first things that happened is that they created a high-risk pool that basically allowed, insurance companies to dump some of the higher cost people into this pool to try and, help insurance companies. They also went through and that they said that, people who are 26 can stay on you can stay on your parents' insurance till you're 26. So that helped a lot of college students and a lot of young people. So there were a number of things that kind of passed along the way, but it was really kind of in 2000, but most of it's not going to be implemented until 2014. But what happens then is that instantly some of the Republican states start to challenge it, start to say, oh, we're going to challenge this in court. And so in January of 2011, right? So, this is just a year after it gets passed, is that a Florida judge rules that it's unconstitutional. And then it goes basically to the Supreme Court. And the Supreme Court, there are 26 states who are basically signed on to this, saying is that this is unconstitutional. And the part that they said was unconstitutional was making people buy health insurance. And so it goes to the Supreme Court. And so then, it lies with the Supreme Court. The Supreme Court then can either decide that they're going to uphold it and make people buy health insurance, or they're going to not uphold it and say, nope, so you can't force people to buy health insurance. And so therefore, the Affordable Care Act is dead. So what'd they do? Well, first, the Supreme Court said, you can't make people buy health insurance. So that initially was seen as Affordable Care Act is dead. But then they also said, oh, but you can tax people. And because Congress can tax for whatever you want to tax for, right? That's the power of Congress, is to tax. And so they also said, well, so even though you can't force people to buy insurance, you can fine them. You can tax them if they don't buy insurance. So essentially that saved the individual mandate, because the individual mandate never said, well, we're going to throw you in jail if you don't buy insurance, or we're going to, take your home away or something like that. All it says is that we're going to give you a tax. And what the Supreme Court said was that the majority of the Supreme Court said, that's fine. You can tax people. So that was the, and so, that's what kind of happened. The Supreme Court kind of went through and then upheld major parts of it. It also, though, during this period, this is what led to the Tea Party, and the Tea Party then that now dominates the Republican Party kind of arose during this period because they were so against these Republicans were so against the Affordable Care Act. And presidential hopeful Mitt Romney, who ran against, remember Mitt Romney, the governor of Massachusetts, who passed through the Massachusetts plan. He was running, he was the Republican nominee in 2012 against Obama. And he was basically then started saying, well, that's a bad law, even though it was based totally upon what he did in Massachusetts. So there was a lot of hypocrisy going around. All right, but the Supreme Court also said is that, it said that, well, the Affordable Care Act can't force a Medicaid expansion. So, for example, the original law said that the government would pay for Medicaid expansion Medicaid expansion was like a major part of the Affordable Care Act, would pay for Medicaid expansion for 100% for 5 years and 90% thereafter. And if states didn't accept it, then they would lose all Medicaid money. So essentially, the states would be forced with having to, with not getting any money from Medicaid. Well, this was challenged in court also. And the court then said, for reasons that I've never really understood, they said, well, the government can't force states to accept the Medicaid expansion. And so therefore it'd be up to these states whether to do it. And so, mostly Republican governors said that they wouldn't do it. So the Supreme Court, upheld the constitutionality of Medicaid expansion, but basically limited Health and Human Services to enforce it. Therefore, it just made it optional for states to do it. And as a result, a lot of states to this day still don't have the Medicaid expansion. So why did Obama choose this type of path? Well, he chose the Massachusetts plan because he was basically trying to get Republicans on board. There was also at the time a push for a public option. Well, what people wanted is that they wanted to basically have have a government kind of almost like a Medicaid type of plan also available to people, so that if you could either buy private insurance or you could basically buy into Medicare, is what they wanted done. And this was knocked down because the insurance companies really didn't want it. And so what Obama was doing basically is like this type of plan benefited insurance companies because it got more people to buy insurance, and it didn't harm insurance companies because the government wasn't offering a plan that was going to compete with it. The other thing it did is it increased payments to doctors from Medicaid. And so, before the plan was even unveiled, Obama had brought in the American Medical Association and got them on board. So Obama, the smart thing he did was that he got the insurance companies on board and he got doctors on board, and he gave it to Congress and let Congress do it. These were the three lessons that kind of came out of that, looking at the failed Clinton health plan. That said, the political opposition to it was fierce. Sarah Palin, who was, John McCain's vice presidential nominee in 2008. She said that, that this was going to lead to death panels, and that, seniors would be denied care due to their old age, and they'd be pulling the plug and things like that. So it led to this sort of, big kerfuffle over whether or not the Affordable Care Act was basically going to lead to rationing. It also is that, they set up an independent payments advisory board, which is to begin the authority to recommend cost-saving changes. But as usual, is that, that when this thing was set up, is that they actually prohibited the board from making any changes that would save costs. So again, even though the Affordable Care Act was passed, it wasn't passed as a way it was going to reduce costs. It was basically a plan that was going to get more people health insurance, and that's what it was. All right, so it spawned the Tea Party movement. Led to, in 2012, massive defeats for the Democrats, or 2010, massive defeats for the Democrats in the House and the Senate. It led to all these different challenges, different type of challenges of the Affordable Care Act. So, the first of them survived, but then there was a challenge to the individual mandate, and the Hobby Lobby case. Hobby Lobby, which is the craft store down there on Olive Street. Well, their owner has some certain type of ideas of what kind of contraceptive should be offered. So this went all the way to the Supreme Court, and the Supreme Court said, no, you can't tell Hobby Lobby what type of contraceptive to offer. So there are all these different types of challenges going on. In the end, all these challenges that were successful, they didn't really change the Affordable Care Act very much. I mean, like the contraceptive mandate that the Roman Catholic Church didn't want to cover. So it meant that people who work for the Roman Catholic Church don't get offered birth control. And it was kind of like, well, so what the Health and Human Services basically did is said, well, they'll fund your birth control if you need to. So they made it available to people. So there were lots of challenges, but none of them really had the effect of gutting the Affordable Care Act. Meanwhile, this became the primary thing that the Republicans did when they took over Congress in 2010. So starting in 2011, they just have a running total of, here's all the votes that they took to basically repeal the Affordable Care Act. So by March of 2014, the House had taken 54 votes to repeal the Affordable Care Act, that's a lot of votes to repeal the Affordable Care Act. Of course, it didn't go anywhere because, it's got to be approved by the president. And so the president would just veto anything that came along. So it never actually, led to bills, but it was just like a symbolic. The Republicans were were saying is that, look, we don't like the Affordable Care Act, and as soon as we get into office, we're going to gut it. And the Republicans got in office. In 2016, when Trump was elected, they also took over the House and the Senate. And so, one of the first things Trump did is basically try to weaken the Affordable Care Act. So they changed the individual mandate from $900 down to $0, and made it so the IRS couldn't enforce it. So what they thought that would happen is that would lead to a death spiral, right? Is that then that would essentially lead to people to stop purchasing health insurance. And that's even what Trump said. Trump said that he wanted to make the individual exchanges unstable and put them into a death spiral. So there were a number of different things that happened. And then in 2017, there was a formal vote to repeal it. And so remember that in the Senate, you have to have 51 votes to basically pass this. So the Senate voted 51-48 to repeal the Affordable Care Act. And through the budget reconciliation process, all they need is 51 votes. Trump was sworn in as president on the 20th. In March, they announced that they're going to do their replacement. And then they're going to go forth with the replacement. But then they withdrew the bill, and it went into this weird period where the Republicans were, didn't really have a bill to replace it with. And it was kind of astonishing because you think, if you have 54 votes to repeal something, you'd have some type of replacement there ready to go, but they didn't. And part of the reason is just because it's, it's really hard to replace the Affordable Care Act. So what happened is that, basically Senate votes to proceed on debate on that, on whether or not to do it. They then have what's called a skinny repeal, but it was defeated. So Republicans, Susan Collins, John McCain, and Lisa Murkowski went with the Democrats and the Independents, and they didn't pass it. And so as a result, that was it. And so it died. So why didn't the Republicans repeal the Affordable Care Act? Well, like I said, it's really hard to do because it would have put 20 million people out of without insurance. And because the Republicans wanted to keep they wanted to keep the no pre-existing conditions clause. But the problem is if you keep the no pre-existing conditions clause, because it's really popular, but you don't require people to buy insurance companies, you've got adverse selection. So insurance companies will just, would just and there's no more subsidies, so they were going to cut the subsidies for the Affordable Care Act. So it means that people would be paying full price for all this and they wouldn't buy it, and so it would go into a death spiral, and that it would put 20 million people uninsured. And so that's what really caused the defeat of it. It wasn't that they didn't want to repeal the Affordable Care Act, is that they didn't have anything to replace it by. And the whole reason they didn't have anything to replace it with is because it's really hard to replace something and to keep the no pre-existing conditions clause. Anyways, meanwhile, there was went through another challenge to it, this one from Texas. And the Texas one said, well, since the penalty is zero, right? Since Trump reduced the penalty to zero, it's no longer a tax. And so since it's a tax, the whole individual mandate is unaffordable. And so the Affordable Care Act is no longer constitutional. This never made much sense from a legal point, but they got a conservative judge in Texas to agree with it. And so, once one federal judge agrees with it, then it's going to go to the Supreme Court. And so that's what it did. It went to the Supreme Court. And then in 2020, Supreme Court said, no, the law stands. So that's probably the end of the legal challenges to the Affordable Care Act. So I think where we stand right now is that, the Affordable Care Act is it's going to stay in existence, because I don't think the Republicans will try and repeal it anymore. And the reason they won't is because, one, people like it, right? The popularity of the Affordable Care Act increases a lot during this period. But then also they have nothing to replace it by. And so, it's really hard to go through and to throw 20 million people off of health insurance. And so it was a big deal. I mean, I think that, if you think about the timeline of getting people universal health care, it started in the, 1912, the first discussions of it. And it took 100 years basically to get universal health care, or what's passing for universal health care in the United States. So that's why Affordable Care Act, big deal, can't be underestimated. And that's the end.